Hello, welcome to today's episode of the Aging with Ability podcast. I'm Christine Gorsick. I'm a physical therapist and I'm a clinic owner. And today I just want to talk a little bit about Medicare and physical therapy. So, having about 7 years of experience as a PT and working in 3 different settings, I have had a lot of conversations about Medicare and physical therapy coverage. And so, I just want to talk a little bit about where physical therapists work and a couple of the different settings and how Medicare pays differently based on the setting. And then a little bit of information about what to do if you are seeking out physical therapy. So, a couple of resources on how to find a therapist, and maybe some food for thought for the setting that's right for you, depending on your coverage and your mobility level and what you're seeking care for. So first of all, just kind of where you can find physical therapists. So quite a few places. So the hospital, of course, is one, and there's a whole therapy team at a hospital. So physical therapy, occupational therapy, speech therapy, usually respiratory therapists as well, depending on the hospital size and their specialties. So that's first place, very acute care typically. And then kind of a step down from hospital level of care is what we call skilled nursing or a rehab facility, sometimes called a SNF, like skilled nursing facility, SNF. SNF is the shorthand for that. So that has 24-hour nursing care. All of the caregivers there are CNAs typically, which means they're certified nursing assistants. And then the therapists are there, and you're usually going to get 5 to 6 days a week of therapy. Sometimes, you might only get like PT or OT on one of those days because of if they have 7 days of therapist coverage. So it depends. Some facilities, it's Monday through Friday and you have the weekend off, or only a PT is there on a Saturday. Very much depends on staffing level, size of the facility, et cetera. I've worked in a very small facility that had 20 beds, and we had one physical therapist that came in on a Sunday and saw the kind of higher acuity people. So they were on 6 days a week, and I would see them Monday through Friday. And we had an OT, so that was Monday through Friday. I've also worked in a little bit bigger facility, about 65 beds, and we had a 7-day-a-week service at one point. So that means that, maybe one patient would get no PT on Tuesday and Friday, but they would be seen Saturday and Sunday. So very much depends on why the person is there, what type of facility it is, and staffing. But Medicare is minimum 5 days a week if you are on Medicare A, which we will talk about in a little bit. Kind of another step down from that is home health. So a lot of people leave the hospital or leave a skilled nursing facility with a referral for home health. And for Medicare to qualify you for home health, the nurse or therapist who comes to see you for that first visit, called a start of care, has to fill out some paperwork saying that you are what is considered homebound. So you're homebound if it takes a lot of effort for you to leave the house, if you have to have a caregiver take you, if you need an assistive device, if you need like oxygen or a certain type of wheelchair. Basically the idea is that if you were to go receive these services, whether that's nursing for wound care or catheter or medication education or things like that, or if you were told you needed to get to an outpatient physical therapy clinic in your local clinic twice a week, that you would be so fatigued, or that would be such a burden, that by the time you got to those appointments, they wouldn't really be worthwhile for you, because the effort, the taxing effort of getting out of the home, or the equipment required, or the conditions you have, make it so difficult that in-home is the most appropriate place for you. So that is what is being assessed for at a start of care. And I've worked in home health about 4 years, and definitely there's been times where I've showed up and wondered why this person got a home health referral, because they're doing great, they're back to driving, et cetera. So sometimes that decision to refer to home health happens, on day 2 or 3 in the hospital, and somebody can make a really big turnaround. But because the wheels have already started turning on that referral, they still get seen at home And that's kind of part of what that clinician's job is to make sure that you're an appropriate fit, just because of the way Medicare certifies home health and pays for it, and the state requirements and accreditation and things they're under. So yes, I have a lot of experience with that homebound term. So the other setting is outpatient clinic, which is probably what most people are, familiar with. You drive by a shopping center or in your hospital, there's a clinic that says outpatient physical therapy. Some of them are even inside like doctor's offices, orthopedic clinics that kind of have their own in-house physical therapy clinic. Chain clinics that have the same name, like out here in Oregon, Therapeutic Associates, or ATI is another really big chain clinic, or, standalone clinics, local city clinics, things like that. So those are outpatient clinics, young people, older people, big variety that you see there as a therapist, or, if you're a patient and you're going into the clinic, like I worked in outpatient, and, I saw like a 3-year-old, and then I would see a 90-year-old in the same day. So very big variety, which is really fun in ways. But it definitely, you don't go as deep into some of those specialties necessarily, unless that's really your focus and you can work in a clinic where they can pare down your clientele that way. And then the last one is in-home outpatient clinic. So this is actually what I have, is my own, what we call Medicare B in-home therapy. So what that means is that you don't have to fulfill those homebound requirements like I was talking about before. You could be someone who's driving, doing whatever, going out and about, seeing friends, etc. No mobility issues necessarily, but maybe, you just had surgery or you have some pain and you want to have it treated. So there are Medicare B physical therapy clinics, and then that just means that that person comes to you. They may bring some equipment, just like home health, but you don't have to be considered homebound. So there's not that concern about, oh, I went out and about, or I'm doing better now. I'm not going to qualify for this coverage anymore. That's not a concern with that. And the advantage on the therapist side is, I don't have to worry about making sure you're, at a certain level of mobility. We can set your goals, etc. But also I can own my own clinic, and I can do that myself because I don't have to have a nurse and an OT and a PT and a speech therapist and everything to make up a home health agency. So I can be my own clinician, my own clinic owner, and not have to pay rent at a clinic, not have to have a lot of overhead of a front desk person. So my clinic is just myself and then someone who does my billing, which is wonderful because that's a very difficult side of the business. So that is a nice kind of entry point for a small clinic owner. And then I also get to see people in their homes still, which is nice. It just has a different pace to it, different way of scheduling. So now that I've said kind of Medicare A and Medicare B a few times, we can talk about that a little bit more. So Medicare A, is typically that more acute care coverage. So in the hospital, in the skilled nursing, kind of more of inpatient side of things. So higher acuity, they're going to cover, usually with skilled nursing, it's about 21 days per like diagnosis per stay. And then there's usually a year cap on days that they cover at the facility. So usually it's 100. But you either have to appeal for more than that 21 at a time if things are just more serious or taking longer than they expect, or, if you get admitted again later in the year for a different issue, kind of that 21-day timer starts over. So again, I've worked in skilled nursing quite a bit, but I'm not on that like billing communication side as much. We definitely have rehab meetings and talk about when that person is going to discharge, and a little bit about they might change to a different pay type, things like that. So that gets a little bit complicated, but that's all under Medicare A typically. So hospital, inpatient rehab, somewhere you're staying 24/7, that's under Medicare A until, those benefits run out or change. Home health is kind of that same idea. So it's covered differently than Medicare B. So they do kind of this bundled payment thing, which is again, kind of complicated. But typically what that means for the patient is that there's no out-of-pocket cost. They typically have to meet their deductible, but there's no out-of-pocket cost after that in most cases. And especially because home health usually comes after you've been in the hospital or been in skilled nursing. Maybe you've met some of those qualifications while you had that bigger, more expensive hospital stay, and then home health comes along. So that's kind of all under the umbrella of Medicare A, which is usually, kind of basic coverage. So then outpatient clinic and kind of like the in-home model, like I was talking about that I do myself, that's Medicare B. So that is just another part of Medicare. And this is where it gets a little bit more complicated because a lot of people have Medicare Advantage plans, and that is part of their Medicare B coverage. So if you have like a Blue Cross Blue Shield or United Healthcare Medicare Advantage, then if you go to an outpatient clinic, they're going to run your benefits and look at, that Medicare B portion of it. So what this commonly looks like from a clinic side and what conversation I have with my patients is, do they have a copay? So that's one of the biggest differences between that A coverage and B is there a copay or coinsurance? So copay is, when you see your insurance card and you go to see your doctor and it's, $20 a visit. Same with therapy. It could be 25, 30, 35, depends on your plan. And that's a little bit different than a coinsurance, which is a percentage. So that means that what the therapist bills out and then what insurance pays, they expect you, to cover 20% of it. So let's just use nice, easy numbers. Let's say that insurance said they would cover, the visit was worth $100 according to their billing schedule and things like that they do. So then they would pay 80 and they would expect you to pay 20. So depending on that split of the co-insurance percentage, it may be fairly equal to a copay amount flat rate, but you're not going to fully know the amount exactly till after all the billing has gone through. So some clinics will collect kind of a estimated co-insurance, $15 or $20 a visit, just to kind of keep you going and not make it this big lump sum at the end. And that kind of helps on their, intake side. But that's the difference between co-insurance and copay. So once you pay that copay, you're not typically going to be asked later for more money because that's what your insurance company has said that you're responsible for, and you've already paid that. So the other thing with insurance is visit limits. So some of them have like episode visit limits. So let's say you went to physical therapy for knee pain, and they're going to say, okay, this episode of knee pain or this post-surgical episode has, 20 visits that you can use for PT and OT. Sometimes it splits it with different therapy disciplines. So that's something to look at as well. And when you're signing up for a plan or when you are understanding your benefits, when you're seeking out physical therapy, some of them have kind of a yearly cap. So a lot of times I'll see like 60 visits a year, and that includes PT and occupational therapy and speech therapy. So when that kind of comes into play the most would be like neurological conditions or something that lasts, a chronic condition that potentially you're seeing multiple disciplines for, or like pediatrics. A lot of times kids will be seeing like a PT and an OT, or even a speech therapist too. So that's when you have to start to get a little more strategic, depending on what time of year it is when things start or what type of plan you have, and making sure, especially as the year gets closer to the end, that you haven't gone over those caps, because then you're going to start being charged like the full price as a self-pay patient after that if insurance is capped out and there's no, kind of appeal or things. So that's kind of the overview. It is complicated, and Medicare is very complex, and especially when you add these advantage plans, and it's not just as simple as, oh, I'm seeing a therapist, it should be covered the same all the time. And I think that's what gets most confusing for people. I constantly get asked, oh, is this covered? Is this covered? Is this covered? And there's even other kind of layers to it that I didn't get into. Like there are certain Advantage plans that set authorization limits. So they might say, oh, this diagnosis, we see, you probably need like 8 visits of therapy. So if we see them for 8 visits, that's it, unless we can ask for an extension and show progress and show that maybe with 3 or 4 more visits, they would, get further. So there's a lot to it, and every situation is a little bit different. So we'll get to the next part here. So kind of just helping you go forward with this information. So some things to consider: knowing your insurance coverage. So it's definitely important when you sign up for your plan, or if the year changes over like it just did recently, and you might not know your full coverage, to kind of print those things out or get that pamphlet they send you in the mail and kind of read through it and try to understand it as best you can. Typically, there's kind of even like a glossary of terms, or ways to understand some of these terms like coinsurance, copay, and the difference there, because it is very complex. Secondly, just kind of thinking about if you go to seek physical therapy, now that I've talked through kind of home health versus outpatient, which one is more appropriate for you? Because that's going to be kind of the two that you'd be seeking, besides needing like a hospital stay. So if you consider yourself to be in a place where getting out and about is very difficult or requires a lot of effort, or a caregiver, or equipment, and things like that, then maybe asking your primary care doctor for a home health referral would be more appropriate. Or if you're someone who has like a wound or a catheter or something more complex that nursing and therapy would be appropriate for you at home, that would be another excellent way or resource to get home health. If it's something, a little bit more straightforward, like some back pain that's been bothering you, or knee pain, or you're thinking about having a joint replacement soon, but you just want to go see a therapist to work on that pain or prepare for that surgery, then outpatient is probably more appropriate, or an in-home outpatient if that's available in your area. So I do have 2 websites I'll put at the video notes or the podcast notes. The first one I'm going to put down there is called PT on ICE. That stands for Institute of Clinical Excellence. And then it's the Find a Clinician tab. So this is a great directory of physical therapists, I think occupational therapists too, that have put their information on this site. And this also means that they've taken an Institute of Clinical Excellence course, which is just a very high level of continuing education. They do have certifications in different areas, including management of the older adults, where we really look at the research on using resistance training and how to get people challenged enough, even if they have multiple comorbidities like diabetes, heart failure, etc. So I've taken one of their courses so far, and thinking about a certification with them. So I will put that website, because that can kind of help you look at your area, and maybe if you have a specific diagnosis like pelvic health, like incontinence, or you are an older adult and you just want someone who really has a passion for working with older adults, that would be a nice resource to narrow it down. The second one is choosept.com, which is a little bit more of a broad website. And so I'll put that one there as well, but I would definitely recommend the PT on ICE as your first one if you're looking for a local clinician. And then, before you go into that clinic, have that conversation on the phone about your coverage. So typically what I do with my clinic is I take in some intake information depending on, where I get my referral from. And I'm going to call that person and collect any more information I didn't get from my referral. Maybe their insurance number wasn't on there. It was just their name, date of birth, and their phone number and the diagnosis or something like that. So I'll collect that information, kind of give them my initial, idea of what it will probably look like with insurance, knowing who I'm contracted with and who I'm in network and out of network with on the phone. And then I'll send that to my biller to do kind of the full analysis of what their coverage looks like. And once I've received that information, do they have a copay? Do they have a coinsurance? Do we have a visit limit? I'll give them a call back and I'll schedule. So that's my workflow, partly because I am such a small clinic. I don't have a front office staff. I don't have all of that behind me to do some of those things. So I'm having those conversations one-on-one. But again, if I have any questions that they're asking me about very detailed things about their coverage, I'll refer that to my biller to have a conversation with them directly. So don't be afraid to ask further questions. Say, what is this bill going to actually look like? Or, maybe ask questions of the clinician or, how's this going to help me? How many visits do you think I need? Those are all great questions at the eval. And especially if you come in with goals in mind, that really helps the therapist make appropriate goals and make appropriate timelines for you, their best guess. Obviously, we don't magically know that you're going to get this much better in this many weeks, but based on our experience and based on how committed you are to doing some of the things you're, being asked to do outside of the sessions, that can make a big difference in your trajectory. So I hope this helped to explain a little bit more about Medicare and physical therapy. And if you're watching the video version, you got a little guest star, one of my cats, Turbo. So hope you enjoyed that too. But let me know if you have any questions. You can always email me. It's Christine@agingwithability.com. And, check out some of my other resources. I have a few printables available on my website as well, and I can link to those in the video notes. But thanks for being here.